Buenos días todos. Good morning, everyone. The New York State Latino Gay and Bisexual Men's Health Summit is an initiative funded by the New York State Department of Health, ACE Institute, and is taking place virtually on August 24th to August 26th. It allows a safe space where we can discuss ways to improve services, strategize how to overcome health challenges, and unify our efforts to end the HIV epidemic. This year, we are offering 3 virtual seminars aimed at addressing issues related to stigma and develop a common vision to address health disparities in Latino, gay, and bisexual communities. This is our second webinar. It's called Racial, Ethnic, and Sexual Minorities in Research. And we want to ensure that people from diverse backgrounds join trials and research. This is key to advancing health equity. Participants in research and clinical trials should represent the patients that will benefit from it. And this is often not the case. People from racial, ethnic, sexual minorities, and other diverse groups are underrepresented in research. In this webinar, we will discuss challenges in involving these groups in clinical research. Challenges include low income to participation, the investigator's bias, medical mistrust, and many other issues in the minority communities. Today, this is Daniel Castellanos. I'm the Director of Research and Innovation at the Latino Commission on AIDS, and it's my pleasure to have Dr. Jorge Soler. He's a public health researcher, social scientist, and sexual health advocate. He was born in Colombia, hola compadre, and raised in an immigrant community in New Jersey. He then earned his MPH, his Master's in Public Health from the Johns Hopkins Bloomberg School of Public Health, and his PhD in Health Behavior and Health Education from the University of Michigan School of Public Health. Currently, Jorge is a sub-investigator and junior faculty member with the Project Achieve at the New York Blood Center. His research expertise is on the role of social support in the mental and sexual health of young adult Black and Latino gay men. He's also interested in examining how social support networks can improve uptake of interventions like PrEP for HIV prevention and vaccination for COVID prevention. So with all that, again, it's my pleasure to have you here, Jorge. The stage is yours.
All right. Thank you so much. Let me share my screen to get started. Here we go. Yes, as always, Daniela, at this point, I've gotten to know you really well over the last few years. It's nice to cross paths with you again. And I just want to thank Luciano and this summit for this invitation to speak here, to share some of my perspective, my work, and I think some of my vision where I want us to see us moving forward in terms of doing research with the populations that we're so invested in on personal and professional levels. So for starters, my presentation, for starters, I'll talk a bit about some of my research and practice background, just a couple of minutes. Some of that was already covered in my intro. I'll give an overview of LGBTQ populations and how we measure some of these things related to identity. Importantly, I'm going to talk about health behavior paradigms. So it's really getting at the question of how do we think about health and how does that influence how we think about people's responsibility around their health, how we measure health behavior, and how that influences policy and intervention development. And then I'll use examples looking at mental and sexual health of gay and bi men to talk about how these health behavior paradigms shape the way that we do research and the kind of messaging that we disseminate from research. And then I'll end a note of resilience to round up the conversation. So again, a quick history about me as a researcher, because this is the lens that I bring to my work. I was born in Colombia. I immigrated to the US when I was 5 years old in 1985. HIV has impacted my family directly. My father passed away from AIDS-related complications in 1991 when I was 11. And so the subsequent conversations in my family around HIV and sexuality really has shaped the way I do this work. And also after college, doing a lot of volunteer work in New York City with Latino gay men of New York and gay men's health crisis really shaped me as a community-based researcher. I also worked for 5 years at a Latino health agency in Boston, Massachusetts. So this really solidified my commitment to community work. And also where I did my PhD at the University of Michigan, I was involved with a lot of community-based participatory research, or CBPR. And one of the tenets of CBPR is that community members bring expertise that's as valuable and equally valuable to the expertise that researchers bring. And I really live by that in the work that I do. And to the best of my abilities, incorporating community's perspective and voice to inform the work that I do. My areas of expertise, as mentioned before, is in social support and young adult queer men of color. So asking questions like where do they get social support? What kinds of support do they want and need? And how is this important for mental health and for sexual health? And more recently, I'm looking at social support networks and asking questions of how can we use social support networks to better implement HIV prevention strategies like PrEP, and also moving forward, injectable PrEP and also COVID vaccination. And so this comes from a very implementation science perspective, where we have these tools that work really well, and they're highly effective, but the uptake has been very low in certain communities, specifically in the communities we're going to talk about today. So, at this point, we have a pretty good idea, just nationwide, how many LGBTQ people there are in the US. About 4.5% of the population identifies as LGBTQ. Here in New York City, it's about 5.1%. That represents almost 1 million people. In terms of absolute numbers, we're ranked 4th in the US for number of LGBTQ people. There are 78,000 people who identify as trans here in New York as well. So we have these great numbers nationwide. And how do we know this? Because we have nationwide surveys, right? A lot of this comes from the census that happens every 10 years. The CDC has their behavioral risk factor surveillance system. And then there's also think tanks and smaller policy institutes that do their own surveys that collect more nuanced information around LGBTQ populations. So with national surveys like from the census, from CDC, because they're trying to capture so much, they might just have 1 or 2 questions that are specific to LGBTQ people. But Gallup and Williams Institute, they'll develop an entire survey that is just about LGBTQ people, so they can ask more in-depth questions. And also just that at the local level, we also have researchers in academic institutions, universities, research centers like where I am, where we're also conducting really in-depth interviews, really understanding people's lives in a smaller community-based sample. So maybe it's not representative, but it's allowing us to understand more in-depth certain local communities. And so all of these sources really complement each other to try and put together a bigger picture of what's happening among LGBTQ people. So just as a refresher, so here's some kind of basic ways, kind of common practices for even asking people about their sexual orientation. And so it's defined by 3 general domains: sexual identity, sexual attraction, and sexual behavior. So sexual identity, do you consider yourself to be? And then here are some of the options. Sexual attraction, people are different in their sexual attraction to other people. Which best describes your feelings? Are you sexually attracted to? And then here are those options. And then sexual behavior. Right? In the past, whatever time frame, who have you had sex with? And then you offer the person certain options here. So this has been standard practice for a while now. Now we all know that there's limitations to these categories, right? And as we move forward in time, these categories are kind of exploding to many different other kind of identities or behaviors that people identify with. In terms of how we ask questions around transgender identity, it's this 2-step approach that people commonly take. So we ask first, what sex were you assigned at birth on your original birth certificate, male or female? And then how do you describe yourself, or what is your current gender identity? And then the options might be male, female, transgender, or do not identify as female, male, or transgender. At my institution, we have an additional option where somebody can identify as gender diverse, gender nonconforming, or gender queer. And again, these are terms that are really changing on a week-to-week, month-to-month basis. Now I present these examples of kind of standardized ways that we are collecting this information, because then I want to focus on this survey that the Trevor Project did in 2020. So this was a national survey on LGBTQ youth mental health, where they surveyed, I believe, is about 40,000, I think 13 to 24-year-olds. And so they also asked them, how do you identify in terms of your gender identity and in terms of your sexual orientation? The neat thing is that they didn't include prescribed categories. They let people fill in, what their identity was. And they found that, in terms of gender identity, people identified with more than 100 different combinations of terms. When they asked about sexual orientation, youth identified with more than 100 different combinations of terms for their sexual orientation. And so this really shows kind of this tension in research. On the one hand, we want to be as inclusive as possible and really capture the spectrum of the way people identify. But there's also, we have to grapple with, all right, well, what do we do with this information? How do we analyze it, categorize it, while still respecting people's individual labels? And so this is, I think, a nice contrast that shows kind of some of the tension around how we just even measure something like sexual orientation and sexual behavior and gender. So what's missing, capturing the complexity of just people's real lived experiences. We know that data collection isn't perfect, so this is something we have to acknowledge. And we know that numbers are explaining better at explaining perhaps how many, where, and who, but not so much how or why. And so this is where qualitative research becomes really important. I'm not going to talk about qualitative research too much in this presentation, but know that it's really critical for us in terms of understanding these issues we're grappling with. And then, of course, something I'm going to go into is just internal biases that shape research. And this is at the individual kind of investigator researcher level and also at the institutional level. And although I'm not going to talk much about, or really at all, in terms of how we measure race and ethnicity, which are obviously like key issues in this work, I just want to highlight that this is a picture I took of a mural that came up after the murder of George Floyd, came up in the neighborhood. So the picture on the right is my picture, where it says, Latinx también somos negros. And it just really resonated with me because I find that oftentimes in the world of research, we still see race and ethnicity as mutually exclusive categories, to the point where sometimes when we talk about Latinx populations, Black people within that population become invisible. So I think this is something we're still struggling with ourselves in terms of recognizing the overlap between Latinx and Black populations, and that they're not mutually exclusive. So importantly, I want to think, ask the question as how do we think about health? This is critical because it really shapes the kind of questions that we ask, how we design our studies, and it really helps us highlight the biases that we might unknowingly be putting into the research that we do. So to start, we have this idea of the American creed, right? This idea that, if people work hard enough, they can accomplish anything. It's kind of that pulling oneself up by the bootstraps mentality. And so it's this myth that we all start on a level playing field. And so therefore we all have the equal opportunity to achieve something. What happens with that is then it becomes our, the responsibility to achieve that becomes individual. It's completely at the individual level. It completely falls on us to make that achievement. And what it does is really ignores all the other social and structural barriers or factors that can influence somebody's actual ability to achieve something. And this is really, it's really fundamental to the way we even talk about what it is to be American, to be in this country, right? It's part of the American dream. And so I see this really creep into all facets of life, including queer life in pop culture. So specifically, I want to draw your attention to RuPaul's Drag Race, right? This is the show that at this point is becoming mainstream, right? It's grown a ton over the last decade. There's international versions now. It's not just something gay people watch, straight people watch as well. And so as the show has gotten more attention, right? So this is a show where basically drag queens compete to be kind of the next big drag superstar. And as the show has gotten more attention, it's become more expensive to be on the show, right? A lot of drag queens are not, have been very vocal about when they get invited to be on the show, they're spending upwards of $10,000 to buy dresses and gowns and garments to compete on the show. So already from the beginning, that it's the people who have greater social capital, financial capital, and cultural capital who already have a heads up in this competition. The issue that I have sometimes is with RuPaul, who is the host, when contestants are coming up on some kind of challenge, he often says, I feel like you're being sabotaged by your inner saboteur. And he's making a reference to the kind of this personal responsibility that the queen isn't competing because there's something about herself that she's not addressing. And it's kind of ignoring actually the bigger kind of structural social factors that are putting certain queens at a disadvantage up front. And so I wanted to, this is such culturally such an important show. And I think it's important to bring light to the ways that even within the show that it's as inclusive as it is, you see this idea of kind of this American creed kind of creep through in the messaging. And this is something that's being studied. So Hook and Marcus wrote a great article called Health in the United States: Are Appeals to Choice and Personal Responsibility Making Americans Sick? And so, what they're saying is they're making the argument that when we place the burden of change solely on the individual and the individual doesn't succeed, it just makes them sicker, right? So somebody who's trying to be healthy, but because of their environment, they can't kind of achieve health, we blame them for it, and that actually makes them sicker. And so that stress and worry about health increases. And then as a society, we place blame and stigma towards those who are unhealthy because we're blaming them for that. And ultimately what this does is it widens health disparities. And so I've made reference to these kind of larger social and structural factors. And so these social factors, they can be described in terms of a theory called fundamental cause theory. And so according to this theory, it states that due to underlying inequality, social factors remain linked to health, even if you change the disease, if you change the risk factors, or if you change the interventions. And so I'm going to give you an example about that by talking about HIV and gay men. And so fundamental cause theory states that in a population, even if you change diseases, you'll still see the same health disparities emerging, even if you change the disease. So an example of this is on the panel on the left. It shows a map of HIV diagnosis rates per zip code, with the darker areas signify higher HIV diagnosis rates. The map on the right shows the rate of COVID diagnoses, again by zip code. If you look at these two maps, you see that there's an overlap in the shaded areas. And even though these are two very different diseases, you see an overlap in terms of the population being affected by them, because there's some underlying inequality that's predisposing people not just to HIV, but also to COVID, diabetes, hypertension, etc. So one fundamental cause here is poverty, right? So if I show a map of poverty with the areas shaded darker as indicating higher poverty rates, you'll see that these shaded areas where we see more HIV, more COVID, are areas where you also see higher poverty. And so poverty is a way to explain the ways in which, even if you look at different diseases, they pop up in the same areas. And so fundamental cause theory also states that if you change the risk behaviors, that doesn't necessarily address the health disparities either. And so an example of this is in HIV prevention research and public health messaging. We often, we study condom use, right? We say that if you use condoms, it's a way to reduce HIV. If you decrease your number of sexual partners, it's a way to decrease your HIV risk. If you don't use substances, it's a way to reduce your HIV risk. But what we're finding is that there's accumulating evidence that Black and Latino gay men engage in fewer risky behaviors, quote, risky behaviors compared to white gay men, but yet they're still experiencing more HIV infection. So for decades now, we've basically been telling men of color, and specifically Black men, that if you use condoms, have less sexual partners, and don't use substances, you won't experience HIV infection. And that's just simply not what's happening. It's not true. Black gay men are still experiencing high rates of HIV infection. And that's a paradox, right? How can that be if they're changing their behaviors? But that's because we're ignoring the larger factors that predispose this population to risk. And I'll go into that a little bit more later. And then fundamental cause theory states that even if you introduce a new intervention to address that issue, if you're not addressing the underlying inequality, you're not changing the health disparities. So an example of this is PrEP, right? So PrEP is this thing that we know is has high efficacy in terms of high effectiveness in terms of preventing HIV infection. It works really well. We know that. However, we also know that Black and Latino gay men are less likely to use PrEP. And so this is a PrEP cascade model. So we know that people need to be aware of PrEP, they need to uptake PrEP, and they need to be adherent and be retained in PrEP care. And if those things aren't accomplished, you kind of lose people along the way, right? And if you lose people along the way, then you're actually creating a disparity. And so what happens is that Black and Latino gay men are less likely to be on PrEP compared to white gay men. And so even though you have this intervention that works, because it's not being equally distributed or made accessible, then you're actually widening the disparities because there's an underlying inequality that isn't being addressed. And that perhaps might be racism in medical institutions that breed medical mistrust, and therefore causes Black and Latino gay men not to want PrEP or not to go to the provider to ask about PrEP. And because that underlying inequality isn't being addressed, introducing this new intervention isn't going to change the disparities that we're seeing. And so what are some of these underlying inequalities? So things like access to healthcare, and I should say access to quality healthcare. Redlining, historically, redlining has been a way to really prevent people of color, specifically Black people, from accessing areas that have higher resources. Institutionalized racism in all of its forms, including policing, and mass incarceration, in the last decade has been identified as a fundamental cause of health, just because of the way in which mass incarceration has shaped entire Black communities across the United States. COVID has really not exposed, but highlighted also the inequalities that we see in terms of people's social networks, their connections, their ability to find support. Of course, there's homophobia, heterosexism, the devaluation of any identity that isn't straight or heterosexual. And tied to that is stigma in all of its forms, and intersectional stigma as well. And so we can kind of put all of this into concentric circles to try to understand what are these different social factors that impact HIV risk among young men who have sex with men. And so if you look at the smallest circle, that's what we call the individual level. So things like mental health, substance use, internalized homophobia, these things might contribute to someone's HIV risk. If we look at the microsystem, so the interpersonal level, things like history of sexual abuse, availability of social support, family support, partner violence, these things impact HIV risk among young men who have sex with men. At the mesosystem, also you can call it the community level, things like lack of sex education, peer norms, lack of prevention programs, these things also shape HIV risk. And at this larger level, which is kind of where these fundamental causes, structural factors tend to live at the macro system, things related to culture, racism, stigma, history, changing social norms, institutional discrimination also impact HIV risk. So this becomes a way to not just focus kind of on individual behavior, but start linking how that behavior to these larger social factors. And so I'm going to walk you through that as an exercise to really hopefully shape folks thinking about how do I think about how individual factors are related to these larger factors. So I'll go back to this paradox that I talked about before about why do Black gay men experience more HIV infection despite reporting fewer sex partners and greater condom use. So as I alluded to before, if you look at racism, homophobia in healthcare settings, we know that it exists, right? We know that people of color receive differential healthcare and that there are biases at the provider level and there are biases at the institutional level. That's been well documented. The consequences of that, though, is that it breeds medical mistrust. So of course that makes sense. If somebody has a bad experience with a provider or an institution, they're not going to want to go back. And in the context of HIV counseling and testing, if somebody has a bad experience getting tested for HIV, whether it's because they experience homophobia or whether it's sexual stigma because maybe somebody gasps at the number of partners they report, or they experience racism, they're not going to want to go back, not only to that site to get tested for HIV, but they're not going to want to go anywhere to get tested for HIV. And so what that happens is then you have folks who acquire HIV, and then they're not virally suppressed because they're not in care. They haven't gotten tested. They don't know their status. They're not engaged in care. So they have a high viral load at the individual level. But then when you have many folks in an area with unknown HIV status, then you also have a high community viral load. And so we also know that people people tend to stay in specific social networks, right? So then you have this viral load that exists at the social network level. And you have this cycle that starts to develop, or then the folks in these social networks then have a higher chance of becoming HIV infected just because of the area that they're in or the networks that they're in. And so you have increase in infection, which then leads to, again, increases in viral load. And then there's a loop that happens there. So this is a way in which you can think about how these larger structural factors kind of work themselves down through these different levels to impact individual behavior. And so we also see some of this coming out in terms of, when we talk about PrEP, we know that Black and Latino gay men are less likely to use PrEP, and why is that? And so it's good to explore these beliefs that we have about PrEP and PrEP users, because I think this exposes some of the biases that we have that I think prevent Black and Latino men from wanting to use PrEP. So this first belief, I'm sure a lot of you are familiar with this idea that people on PrEP are promiscuous, right? And that's really rooted in sexual stigma and also homophobia, because it's this idea like, we want PrEP so that gay men can enjoy sex, but we don't want them to enjoy it too much, right? And so the underlying judgment there is that too much sex or too many partners is bad. And a lot of that has to do with the way we think about risk in the HIV prevention research that we do. But a reframing of this from a sex positive perspective is that sex is actually, it's meant to be enjoyed. Another belief is that people not on PrEP do not care about their health. So this is a tricky one because we have a lot of messaging out there. We want people to be on PrEP. We want to offer PrEP as one way that people can prevent, HIV infection. But then when people don't want to be on PrEP for whatever reason, then we start to say, well, they're irresponsible and insert population there. And that could be they, meaning people who are gay, people who are Black, people who are Latino, people who are immigrant. The moment these groups don't do something, it becomes a part of their identity in the way that a behavior isn't attached to identity for white people. And so when we say people not on PrEP don't care about their health, the underlying judgment is that they are irresponsible. But the reframing of this is actually multiple barriers exist to accessing PrEP. Similarly, there's kind of this messaging now. People think that PrEP protects against other STIs. And it's kind of unbelievable to me that this message keeps going around, this idea that you kind of have to remind gay men like, all right, use PrEP for HIV, but remember, it doesn't protect against other STIs. And in some ways, I think that kind of lowers then people's kind of value of PrEP every time you kind of point out this supposed kind of the fallacy around PrEP, which doesn't actually make sense. And I have yet to see a survey that shows that people think PrEP actually protects against STIs rather than HIV. I just don't think that people are actually thinking that. But then there's this idea, this population is misinformed. But a really reframing of that is that condomless sex is an option. And I think that's the real fear around, in terms of sexual stigma. Then there's this belief that, people think PrEP does not really work. And so again, what becomes the underlying judgment is, oh, well, that population is misinformed. Again, the population being the ones I mentioned before. And the reframing of that is that medical mistrust is real. Maybe people don't think it works because they have been discriminated against in the past. There's a legacy of that, but also you don't have to look back to Tuskegee. You can just look back to yesterday and people will have an experience of, of discrimination in a healthcare setting. And so that medical mistrust, yeah, it's real, it's there. And so it might cause people to think that maybe PrEP doesn't really work because of their past experiences. And so that was a bit about sexual health and the way in which, these larger structural factors impact PrEP use, for example, and impact HIV risk. Now I'll talk a bit about gay men's mental health. So this was a national survey done, mental health status among US adult men by sexual orientation and identity by Gonzalez in 2016. And so they looked at psychological distress and then categorized people as having none, moderate, or severe distress. So if you look at folks who reported no psychological distress, that the highest percentage of those folks were heterosexual, then gay, and then bisexual. If you look at folks who reported moderate psychological distress, the lowest percentage was among heterosexual, then gay, and then bisexual was the highest. And in terms of those reporting severe psychological distress, the lowest was among heterosexuals at 3%, 7% among gay folks, and 10% among bisexuals. And so this is showing that there is, at a baseline level, disparities in terms of psychological status by sexual orientation. And specifically among queer populations, bisexual men are reporting, and this is consistently report higher rates of psychological distress. So one theory is that bisexual individuals are experiencing discrimination from the broader heterosexual population, but also discrimination within the queer population from other non-bisexual queer people. And so back in the day, we would think that because gay people had higher rates of psychological distress, that this was something that was inherently wrong with queer people. That's something that was endogenous to who they are. But we know better now, right? We have sexual minority stress theory. And so this kind of is a way to explain how our experiences in the world become internalized. And so if you go from left to right, you go from distal, outer, to proximal, internal. So you can say, you know, somebody at the distal end, somebody's experiencing violence and rejection and discrimination because of their identity, right? And that can be a combination of identities. Once they experience that over and over, they start to maintain those expectations. So there's kind of a vigilance, right? A hypervigilance. They're always being aware that this might happen again. And that starts to contribute kind of to anxiety, actually. And so then there's concealment, right? In order to avoid further violence or rejection and discrimination, somebody might change the way they talk, that they dress, the way they carry themselves, start to hide certain parts of themselves. And that kind of concealment also takes a psychological toll on someone. And after a while, if somebody keeps hearing these things or experiencing this discrimination, they actually start to internalize that and believe those things about themselves. And that then becomes manifested as depression. So this is an example, and it's important because this lets us know that these higher levels of psychological distress have a tie to what people are experiencing out in the world. And, you know, and a clear example of how this happens at the institutional level is the fact that homosexuality was categorized as a pathology up until 1974 in the Diagnostic and Statistical Manual of Mental Disorders. And so this is a manual that guides clinical practice, public health research, just research, psychological research in general. And so really it wasn't until recently that we were thinking of homosexuality as something that wasn't pathological or inherent about LGBTQ people. And so just to kind of round out the conversation in terms of, you know, ending on a higher note in terms of resilience, we also know that queer people have tremendous resilience, right? We see some of our queer pioneers here on the screen. It's because of them that we're able to have safe LGBTQ spaces throughout the country. And so this is where some of my research focuses on is social, as I mentioned, social support. Where do people get social support? What kind of social support, and how is this important for health? And specifically, like during the COVID pandemic, we really saw community show up, right, and show out in terms of how community-based organizations, how queer communities, BIPOC communities really rally to funnel resources to communities during the COVID pandemic. And so these are some examples of how that happened throughout the pandemic. A lot of my research has focused on chosen families and how that's a source of support for queer communities. And the reason why I've chosen this is because, you know, in HIV prevention, public health research, oftentimes when we do that research, gay men's relationships are often kind of shown to be negative, right? There's, in terms of these are risky relationships because of sex, because of substance use. And so for me, as a way to push back against that, a lot of my research focuses on the strengths of those relationships between queer people, between gay men. And we know that queer people are really great, are very resourceful in creating chosen family networks where they access support. I think a parallel to this is, you know, in terms of COVID, in the general population, there was a lot of talk of people forming kind of pods, right, to protect themselves from COVID. This is something queer people have been doing for ages, right? These chosen families are examples of those pods as a way to protect themselves from racism, classism, homophobia. So I see a lot of parallels in the way the general population talk about protection of COVID and pods and networks. This kind of strategy is a strategy that queer people have been using for a very long time for their own safety. And there's a lot of books that have been published about this, or qualitative studies. I published an article about this in 2017 as well. And more recently, this has gotten attention in the show Pose. If you Google Pose and chosen family, you can find a clip that really highlights the way chosen family networks are shown in Pose. And so some of my current research actually focuses, because I'm interested in these, quote, non-traditional sources of support. I have current research that's focusing on the role of casual sex partners as sources of social support. And in part, it's because in social support research with gay men and HIV prevention, whenever we ask about casual sex partners, it's only in terms of risk. If we ask about social support, we ask about social support from family, from friends, from romantic partners, but never about casual sex partners, right? And there's many reasons, because casual sex partners are deemed to be risky in terms of HIV risk. Again, they're categorized as risky sexual partners. There's this idea that it's not a good thing if you have too many sexual partners, that casual sex partners are a bad influence, that they are people who can't be friends, and that these relationships aren't meaningful, right? These are cultural and social scripts that we learn about casual sex partners. And so some of our research now is focusing actually on how casual sex partners are in fact important sources of social support. So just as a quick snapshot, we surveyed 1,400 guys and asked them where they got their social support from, including different kinds of sexual partners. And we found that 20%, or 1 in 5 guys, got social support from their casual sex partners. And so my argument is that we have to think about gay men's social networks in a more holistic way, and not just assume that casual sex partners are, quote, risky partners when we're doing HIV prevention research. And so all of this really stems, again, from culture and social scripts that teach us how we're supposed to think about sex and sexual stigma. So this is a study, but for time's sake, I'll skip it. And then lastly, I'll just say that these are some of the issues that we're grappling with in my own organization. So we have a study called Envío. This is a study focused on 16 to 24-year-old Black and or Latinx men who are living with HIV and living in New York City. And with this study, what we really want to learn is how people's experiences of violence and discrimination impact their engagement in HIV care. And so it's a 3-month study, and participants download an app. And so in real time, they're able to record these experiences they might have on a daily basis. And what we're trying to do is, again, think about how these larger kind of community, social, structural factors are impacting the population's engagement in HIV care. So that's all for my presentation. I hope you're able to walk away with some useful useful advice and really frameworks for thinking about health and how that shapes how we talk to people about health and do health research.
Gracias, Jorge, por la presentación. Thanks, Jorge, for the presentation. It was great. I like the way you explain fundamental causes. Sometimes it's hard to grasp it, the concept, and you provided very good examples. Just a quick summary of some of the things that came up for me, and we have a Q&A board. If people want to put some questions there, that would be great. These are some of the things that came up for me thinking about research and how these social and cultural ideas that are changing about health, about gender, race, slowly enter research. And sometimes it takes some time for research to catch up with some of the changes that are happening in our lives, in our communities. And so I imagine that people don't feel reflected on the research that comes out. The other piece that came out for me is how there has been so much emphasis on the individual behavior and not so much on the fundamental causes, even though that has been changing for a while since Bruce and Link started working much more on the fundamental causes. The other interesting piece for me was how sometimes research is extrapolated from the general public or from privileged populations into minority groups, and we conduct research that might have worked for other groups, and we do it in these groups. And you gave the example of Black men, and we might keep asking the same questions about risk, but without understanding the particular characteristics of Black gay men and the lives and the communities. So I wonder, and I have some questions for you. We have questions open to the public, so please write down some of the questions. One of the questions I have is about what are some of the major reasons that you see for funding applications or for grants that exclude particular groups or particular ideas from the research? What are some of those reasons behind that? And like, for instance, you mentioned something about the questions that we ask about casual partners, and that we don't do enough research on that. So what are some of the reasons why we exclude certain populations, certain groups, certain topics? And yes.
Yeah, so some of this is inherent biases that are rooted in heterosexism, homophobia, racism, classism. So that example, with the casual sex partners, when I thought about the role of chosen family networks as kind of a non-traditional source of support, I started to think about the role of casual sex partners as a non-traditional source of social support, especially because in public health research, that, like I said, they're always classified as kind of like a risky type of partner to have. And so when you're starting off from that perspective, then there's many questions you're never going to ask, because you've already in your mind said, this is a risky group. All I know about them is that they're not great in terms of HIV risk. And so you don't ask any more questions about who they are, what other kinds of relationships do people have with their casual sex partners. And so from the start, just that bias from the beginning prevents questions from even being asked. And if they are, then they're also not great questions, right? The questions might be biased. But I had a really, fortunately, where I am at Project Achieve, they did a survey and somebody had the foresight to ask about social support from casual sex partners, but it's something I hadn't seen anywhere else. It was really difficult to find that research because of that bias. So those biases work in that way. Questions that don't even get asked, or if they do, the questions themselves are biased. There's also, I think, a danger, with HIV, because we have made such great strides in HIV prevention. There's PrEP, there's also U=U, there's injectable PrEP that's coming. Our rates are decreasing, but we also know that certain disparities are stable or increasing when you drill down to subgroups. And so when you drill down to these subgroups and moving away from the broader population, I think sometimes at the broader population, people think, oh, this is no longer a problem at the broader population level. Oh, this is already fixed, right? And in public health, we all know that, the moment you stop doing something, that's when you see the crisis happen. Public health is about maintaining something so that, you don't reach that crisis. And so there's a danger of pulling away funding from HIV research just because on a national level, we think it's okay, but we're ignoring still like the subpopulations, the marginalized populations that continue to be impacted by HIV.
Yeah.
And my fears is that that'll happen with COVID, right? As the dust settles and COVID kind of settles also into marginalized populations, then we begin to think, oh, okay, this is just something that we're just going to accept, that it's just another thing that people of color, poor people have to grapple with.
Yeah, thanks, Jorge. It also reminded me of something that, sometimes we hear about HIV among Latino gay men as something that is kind of happening new. But when you look at some of the data, we saw some of those trends back in the 80s and 90s. So it's no new that we were highly impacted by HIV. I think it's more on the news now. And that leads me to a second question that I have, which is, I just have some numbers here that I wanted to just point out, like only 5.5% of medical school faculty in the US are Latinx, and only 3.6% of the medical school faculty is African American. And in terms of the grants, the R01 grants per race, Blacks get 2% of the grants and Hispanics get about 5% of the R01 grants. So what you have is faculty and researchers that tend to be from communities that are not the most impacted.
Right.
So the question that I have for you is, and I'm going to put that on the chat actually, that data. The question for you is, how do we start dismantling these bias and how we start countering these arguments about us that are replicated in research applications and in research grants and in faculties, in faculty compositions, and etc.
Yes, and the first word that comes to mind is representation, right? We need to have at the table different perspectives to inform the research that we do. So if we only have, white researchers doing research on Black communities, on, Latinx communities, if you only have that perspective, there's going to be biases there. And, this idea that research is objective, I think is a really dangerous idea. No research is objective. It's something that we strive for. It's one of those goals that we strive for, but it's never 100%. And we have to be careful with that idea. And oftentimes, there's this claim that quantitative research is more objective than qualitative research, which, I don't think is true. But yeah, but we need the representation of different people at the research table who are coming together to make sure we're asking the right questions, acknowledging biases. And really, that starts also at the undergraduate level in terms of building people's, some ways, as I was mentioning social capital before, for researchers of color, we need to start finding ways to build that social capital earlier on. As I work on grants myself, a big part of it is getting these letters of recommendation that ultimately, I end up writing myself, right? But a big part of these applications is really just showing how well connected you are, I feel like, to other researchers. And in part that is because, that means there's overlapping research interests, and also that's people who are going to support your work. But yeah, it's really a test of how well connected you are as a researcher. And so it's so important to have programs and opportunities for researchers of color across the nation and across the world to connect with each other, to support each other. And to really foster that sense of collaboration nationwide or across institutions, because even if you don't have that in your own institution, as we see, right, a lot of faculty talk about how they're kind of the token, right, minority in their institution. It becomes that much more important to connect that faculty member to other faculty members in other institutions. But then there's also, we hear a lot that then faculty members of color in their institutions, they're the ones who are asked to be in all of the diversity communities and, and lead all of the diversity initiatives on campus. And that's unpaid work that gets placed specifically on faculty of color. And so I think, then it becomes an issue. It's one thing to attract candidates and faculty. It's another thing to keep them there. That's always been a big issue at any level of education.
Yeah. And I have a question from the audience that I'm going to connect it with a follow-up question I have for you, which is the other side of the coin in terms of involvement of particular groups in research and clinical trials. So the question that someone in the audience, and I'm posting it there, is if we know about the mental distress among bisexual men, how is that we don't target this group much more specifically? And it's also connected to research on transgender women. There is very little, and many studies actually exclude that particular group. Undocumented immigrants, we don't have enough data because we are not collecting some of that data. So how do we also look at the issue of lack of participation in those studies?
Yeah, I think that's where community partnerships become so critical. No one organization can reach everybody. And as I mentioned before, community members, community organizations bring their own level of expertise that's as valuable as the expertise of the researchers. And, I think it's important for researchers to be able to collaborate and work with community partners to reach populations, to establish relationships where, there's so much information out there where community partners have a trusted source they can go to, a research or institution, to kind of make sure, they know what the latest information is. So I think the community partnerships are really important. And I've seen that in my own work as well, especially around like the work I do around vaccines. There's a lot of mistrust there. And really that mistrust can be bridged by working with our community partners to really get in on the ground in the communities that have have that mistrust or have that fear or concern of clinical research.
And what about actually requiring that some of these studies do not exclude these populations from their proposals and from their grants?
Yeah, so I think more and more there are.
That's the other side of the coin, right?
Right. Yeah, and so the example like bisexual populations is a great example because we see a clear disparity there, right? We know like biphobia is real. There's more and more research talking about the specific discrimination that bisexual individuals feel, again, from everyone, from within queer community, for the general heterosexual population. That still remains an area that remains understudied despite this consistent disparity we're seeing. And I think that has to do with not having representation at the table, for people to push and say, hey, you know what, there's this disparity here. We can't just focus on gay, straight. What about the bisexual folks? We see that they're actually, over and over, we see that they're experiencing the most psychological distress.
Yeah. Let me see if we have another question, but I think we are coming to the end of this session. No, I don't see another question, but Jorge, thank you so much. And we appreciate the work that you have been doing, not only in academia, but also out there in the community. We admire you, we respect you. So please join us tomorrow for another session. It's called Intersection of Race, Ethnicity, Faith, and Sexual Orientation, a very important key topic. Tomorrow at 2 p.m. The registration is open and the link is going to be posted on the chat room, so you can go and register. So thank you again and have a wonderful day.
All right. Thank you, everybody.